our first two speakers. Um, Let me see. We have Candace Dufour and we have Susan Leckleitner. Before I do the bios, let me back up and say, if you have questions for Candace and Susan as we are presenting, if you will either hold your questions to the end or if you will preferably put them in the chat. Once they conclude the presentation, I will read the questions to the presenters and have them answer your questions. So anything that you would like to comment or discuss, just please hold it during the presentation and put it in the chat at the end, and we'll make sure to get to that. And I'll be monitoring as we go. Okay, back to the bios. Candace Dufour is a doctorate of pharmacy, and she attended Shenandoah University of Pharmacy in Winchester, Virginia. She is originally from the southwestern part of Virginia. Candace joined the Southern Pharmacy team in 2010 and began her career working as a staff pharmacist. In January 2023, she accepted the position of Director of Clinical Services. Prior to working at Southern Pharmacy, she gained experience in retail and long-term care pharmacy, focusing on IV and anticoagulant dosing. Candace enjoys being a liaison between the pharmacy's customer and the pharmacy departments to allow Southern to find ways to provide superior customer service. Welcome, Candace, to our presentation, to our session today. Our next co-presenter is Susan Leckleitner. She is a graduate of Dyersburg State College with an associate degree in nursing and has been a registered nurse for 37 years. She has worked in acute care settings, long-term care facilities, and long-term care pharmacy. She has more than 30 years experience in geriatric nursing. Susan has worked in long-term care pharmacy since 2000. Susan is also a licensed nursing home administrator. She has worked in several roles in long-term care to include a quality assurance nurse, director of nursing, and long-term care administrator. Susan currently works as an education coordinator and clinical account manager for Wynyard Guardian Pharmacy in South Carolina. Susan ventured out to start her own training school for post-secondary education in 2021. Her school is a training provider for CNAs, CMAs, phlebotomists, EKG technicians, and pharmacy technicians for the healthcare workforce. Susan is married and has 2 daughters and 2 grandchildren and resides in Turbyville, South Carolina. And with this, I'm going to turn it over to our presenters.
Again, good morning. Thank you everyone for joining us today. I'm Candace Dufour and I'll be presenting along with Susan Leckleitner. And we're going to present on continuous glucose monitoring for healthcare professionals. Just to kind of start out, I'll just let you know, instead of saying continuous glucose monitoring 5,000 times, we'll probably refer to it as CGM. And we've decided kind of today to present on this because it's definitely gaining some traction in long-term care. It's something we've not seen very much over the past few years, but more residents are starting to move in and already be using CGM. So we thought it would be nice to educate ourselves along and hopefully pass this along to you as new information or just a refresher if you're already familiar with it. Today, we're going to overview CGM devices, how they work, compare the different devices that are currently available, and compare it to traditional glucose monitoring like finger sticks. We'll go over the benefits and challenges of CGM devices, the nurse's role in CGM implementation, and review some hypoglycemic management. So a CGM is a continuous glucose monitor that is a wearable device that tracks blood sugar levels. These devices are very beneficial. They use the monitoring of blood glucose levels by switching from multiple finger sticks a day, which we all know many residents hate and refuse often, to just getting glucose levels on demand by scanning a device. This also decreases the risk of exposure of blood between the resident and the staff. One of the major questions when we all think of this, because it is so new or newer to us and we're seeing it more frequently used, would maybe be the pricing of this and how do we start this in residents and can they afford it? So the price depends on the device itself. And depending on the manufacturer, and this is not including the upfront device of the cost, but the average monthly cost range from $100 to $300 per month for the use of the CGM for the resident. When comparing this to traditional blood glucose monitoring with the finger sticks, again, looking at the upfront cost, not including the device, that's about $35 to $170 a month per strip. So while we see that the traditional ways still seem much cheaper, we're going to, like I said, look at the benefits and how this just may give us better readings, better advancement in long-term care, and help with adherence as we go, even though device may be a little bit more expensive than the traditional use. Another question that comes up is, can the pharmacy provide the blood glucose monitoring devices, the CGMs? Yes, some pharmacies can, but the cost that varies just depending on the pharmacy itself. These devices are typically billed through Part B or a Medicare Advantage plan, like a bundled plan, not Part D, which the pharmacies are usually the ones, that's what we bill toward. If a pharmacy is licensed for Part B, then they can help get the coverage for that and dispense the device. If a pharmacy does bill for Part B, they typically have to be contracted with a Part B DME product provider, and that's a durable medical equipment provider. Patients also have the option of paying cash when it comes to the CGMs. No one's looking to do that, but it's an option if they really just don't want to use traditional glucose monitoring. So, how the CGM works, it has a sensor that measures interstitial glucose levels. And the interstitial glucose levels, that's the concentration of glucose found in the fluid between the cells. And when we compare that to traditional finger stick monitoring, that monitors blood glucose, which is exactly as it sounds. That's the glucose found in the bloodstream. It has a transmitter that sends data to a receiver or a smartphone, and the readings update every 1 to 5 minutes. An insight to this for those of us who love to just understand the full picture of things and how they work, CGMs use an enzyme based electrochemical sensor to measure the glucose in the interstitial fluid. An enzyme based electrochemical sensor is a type of biosensor that uses an immobilized enzyme to specifically recognize a target analyte, triggering a chemical reaction that produces measurable electrical chemicals, allowing for highly sensitive and selective detection of the analyte through electrochemical methods. This enzyme acts as a biological recognition element, while the electrodes of the device convert the biochemical reaction into electrical signals. And that's how we get the blood glucose reading, the value that we're typically used to seeing. And now I'm going to turn it over to Susan for some types of CGM.
So the types of CGM, I'm going to mess that acronym up all day, but CGM is a real-time CGM and an intermittently scanned CGM, often referred to as a flash CGM. The FDA approved brands are Dexcom, Freestyle Libre, and Medtronic. So with an intermittent, the users have to scan the sensor in order to review the glucose data. They can scan as often as they would like. It updates about every 5 minutes, but it doesn't give any real-time alerts or alarms. So there's a potential for data gaps in that type of device. In the real time, it transfers the data automatically to the device, providing continuous glucose readings and alerts. So this user can set their range of where they want to be, and it can alert them or alarm them if they have a potentially low hypoglycemic event, if that's coming. Some of these devices, and there's multiple devices out there. Medtronic has one, Dexcom, Libre, they have different features. And that's what is going to be important as your resident moves into the facility or they have a new order for these CGMs, is to see what type of device we do have and what's the specifics on that particular device. They say that in the future that we're going to have they're exploring non-invasive glucose monitoring from sweat, tears. Candace and I were talking about that, like how do you do that on demand? So anyway, that will be interesting to see as we move forward in technology, no doubt. So the types of devices, the Dexcom. Dexcom has two different ones on the market right now. They have the G6 and the G7. The G6 is going to eventually be discontinued because the G7 has some special features. And the size of the sensor is smaller. It's a small sensor, looks like about a quarter size. The location of the sensor is typically placed on the back of the upper arm in the fatty tissue. The warm-up time, and I know Candace is going to elaborate a little more on this, but the warm-up time is how long once the sensor is placed that it takes to start reading accurately. So the G7, as you can see, only has a 30-minute warm-up time, and the G6 has a 2-hour. Some of them have 2 hours, some of them have 1 hour, depending on like the model of the device. The sensor for Dexcom can last up to 10 days. And I see that it says up to 10 days. The G7 will actually tell the person on their smartphone app or their monitor that they need to change it. Okay. So if something's going wrong with it, it's not reading exactly right, it could ask them to change the sensor prior to the 10 days. So the G6 will eventually fade out. Some of these monitors, and Dexcom is one of those that is calibrated at the factory, where some of the others have to be calibrated once they receive their device. The Freestyle Libre has the 2 and the 3. And so with that being said, this monitor is more of the intermittent scan device, where they just place either their smartphone or their monitor over the device and they're able to get a glucose reading. It still does track, but it doesn't give that real-time tracking like the Dexcom. But the FDA has approved 3 of them, which is Dexcom, Libre, and Medtronic. And Medtronic also has one called the Guardian Connect 4 as well. So the Libre style, you can leave the sensor up to 15 days. So that is a benefit, no doubt. To make sure that the sensors are working properly, we have to make sure that they're applied correctly and that they are checked at least every 8 hours under this scan model. So the GCM versus traditional blood glucose monitoring, what's the difference? Well, with the GCM, it gives you a measurement continuously, where we know with the traditional blood glucose, we only get a single point on that finger stick. It gives real-time alerts, the GCM does, and the traditional blood sugar, we're only going to know at that particular time what the blood sugar is. Does it trend data? It does in the CGM, and the traditional, it does not. Invasive, when I think about finger sticks, I hate getting finger sticks versus even a lab draw. And there's many residents that don't like that as well. Or like Candace says, they refuse that. As I said previously, some have to be calibrated. The CGMs, most of the glucometers now are very user friendly, but they still require a stick. The accuracy is very high with the CGM, but there's a slight delay because it's interstitial fluid. It doesn't give the immediate blood glucose level. And of course, the cost is higher with the CGM versus the traditional blood glucose monitor. Some strips are expensive depending on the make and model of them. Some are not as expensive. So, but the biggest um, con would be the delay in 5 to 15 minutes with the CGM. So the benefits um, will improve the glycemic control, a reduction in hypoglycemic events. There's some of these devices that their studies show that they do a reduction in the hypoglycemic events from 50 to 85%. It also has personalized data-driven adjustments. So if they need to make an adjustment in their diet or their medications, along with the practitioner, this allows them to do that and increase patient engagement. Candace and I were talking as well about the baby boomers that we're beginning to take care of, and that they want this advanced technology. They want to have this at their fingertips. They may have been using it at home. There was a study in diabetes care in 2021 that found that the CGM led to 50% fewer severe hypoglycemic episodes in type 1 diabetic patients. And we know that a lot of our residents are not type 1 diabetics that we take care of, but I'm seeing this be more prevalent in our assisted living facilities as well. That's what we want to do, is learn these devices, look the information up, so that when they come into our facilities, that we don't know how to take care of them. And I've seen that. I was in a facility recently where they had a resident who moved in and no one knew how to manage this sensor, how to change it. The family was telling them that it needed to be changed and no one knew how to do it. So we had to kind of give them some guidance on that. We also can, with these CGMs, can set a time in range that they're looking, and Candace is going to refer to that a little more, but it gives a range that you can look and see when your time in range is, which is very instrumental in managing diabetes with the practitioner. Okay. So challenges and considerations of the CGM would be accuracy limitations because of the sensor lag. As I said, we're checking interstitial fluid, the fluid between the cells versus the blood. The cost and insurance. We all know with insurance is sometimes very difficult to manage coverage. We have to show that there's enough documentation to prove that they need this type of device. Skin irritation. As we know, the sensor doesn't actually have a needle that remains in place, but the tape, the adhesive, those things can cause skin irritation. And then the sensor maintenance and replacements, making sure that they're being replaced timely. So it does give this real-time data, or this constant or consistent glucose monitoring. Important considerations is the lags behind are 5 to 15 minutes, depending on the device. Skin irritation is reported by 20% of the folks that use the CGM devices. And the calibration needs differ. Where the Dexcom is factory calibrated, other models may require a manual calibration. So making sure that this is happening.
Okay, so we're going to talk about some roles that the nurses play in the implementation of CGM in long-term care. The primary role we're all going to think of when it comes to nurses is education. So we want them to preemptively, educate themselves on this. So as residents move in, they can educate the patients and staff on CGM use. Some may already be moving in, using this for a while, and they will know themselves, but everyone is moving into long-term care for a reason. And a lot of times it is due to decrease in cognitive function. So if they were able to manage themselves before, they may not remember how to do that on a consistent basis. So the nurses are going to need to be there to help and to educate. Second, we also want to ensure that they're able to help the patients and staff interpret the data and trends. If this is something they're switching over to as they come in, or finger sticks just start to kind of go away because of the valuable nursing time that people need to regain from them, and there's a push for CGM in some long-term care facilities, before where we would just look at the numbers and tell them and know that's right, while that's still helpful, we need them to be able to educate them on the trends they see. And we'll go through a little bit more of that in a bit. Something else the nurses will be helpful on, this is not what anybody looks forward to, is helping them to troubleshoot devices. None of us like to troubleshoot anything. We like when everything goes smoothly. Technology is not fun. No one likes change. It's great when it works, but it's horrible when it doesn't. So if the device messes up, the readings aren't going well, that's typically going to fall to the nursing staff. So it may be best to kind of delegate someone as your resident expert CGM nurse. And that way, if you get people with more frequent use of these, that this person can kind of be the go-to to help. You might want to have a few just because of different shifts and when people are off, but we are going to need some experts in that. We do recognize that troubleshooting and any problems like that do take away valuable nursing time. Nurses can also be of assistance when it comes to insurance coverage and advocacy. Again, in long-term care, we're used to most of the time our billing teams in the pharmacies being able to be that advocate, take the pressure off the facility and the nurses for that, save them time by our billing departments taking on the prior authorization. Well, the problem with that is if it's billed to Part B and the pharmacy can't bill Part B, that may shift over to the nurses in certain healthcare settings. We can be in knowledge and try to help and guide them, but we may not always be able to push through the prior auth or get the billing done. Some best practices for nurses. Again, we want to help the patients interpret the glucose trends and not just numbers. We want to educate them on how meal timing and exercise can affect their CGM readings. So residents that are still pretty with it and want to be involved in their own health care, it might be great for nurses or activity members or anyone to be able to help them. Okay, let's kind of do a little bit of an experiment. Let's scan your device before mealtime and after and just see how it works. And when they eat different meals, they can see the changes. And what works for them. Did you eat more carbs and your blood sugar went up? Did you eat more protein and you stayed more consistent? This might help guide them in better meal choices as we go. Same with exercise programs. If they don't want to attend activities and they're frustrated with their diabetic management, maybe we do the same kind of little experiment, and when they see the progress they're making and the better results from exercise, they incorporate more of this into their routine. One of the main endpoints we want to take home from this is that CGM users, they're going to use something referred to, like Susan mentioned before, which is time in range versus just always looking and always monitoring an A1C. Time in range is a little bit newer of a term that we need to become familiar with over time when we see more use of this. And time in range is the percentage of time the glucose level remains in the target range that the practitioner and the patient have typically set together. A common one that I've seen is looking through studies and stuff would be for the blood glucose value to range between 70 and 180. And for the time in range, we want to aim for this percentage of range for them to stay within 70% of that range while they're wearing the CGM. A time in range is a better indicator than A1C because it provides a more comprehensive view of glycemic control. It provides real-time data, like Susan's mentioned before, and it allows for immediate adjustments to therapy. So when you're kind of looking at this and you see how frequent they stay in that 70 to 180 reading range, if they're in and out of that, we can see, okay, today it was this. Was it after dinner? Is it before breakfast? It's lower or higher. We can check that and see the trends easier and make adjustments on a quicker basis than just waiting for an A1C lab to come in. A1C is the measures of your average blood glucose levels over 2 to 3 months. So if we can kind of look at the trends instead of waiting on the A1C to show us what may be the trend, we can manage their care much better. Oops. Setting up the device. Susan will go into this more in a few minutes, of course, when we get into the specific devices on how they're set up. But for setting up the device, you're going to pair the sensor with the reader, and that's done via Bluetooth technology. As she mentioned before, there is a warm up period, and this is the time it takes for the sensor to calibrate after placed under the skin. And as she mentioned, some of these are done before or after, but most are probably done once the sensor is placed. The duration of this warm up period depends per manufacturer, and it can last from 30 minutes to 2 hours. And no one needs to try to go ahead and check their blue glucose before that. It's not going to be a great representation of that. We need to let the calibration happen and then start the readings after that. For device connection, each reader will only connect to one sensor at a time. So that's kind of big. We all know in long term care, maybe we shouldn't be sharing devices on things. Sometimes that happens. And that really cannot be done with this. So that kind of helps with that compliance, regulatory compliance, when it comes to not sharing devices and readers. Like I said, each reader will only connect to one sensor at a time. So just in my own head, try to think of examples of things. There may be a husband and wife that both live in the same long-term care facility. Both are diabetics. Let's say they both have a CGM. If they're trying to use their cell phone that maybe they share as a family to scan their blood glucose readings, that's only going to connect to one of their readers at a time. So that could be a bit of a hindrance when it comes to that. Again, you're only going to connect the sensor to the reader, and that's going to be after the application of the device. So once it's inserted into the body, then you're going to pair them. And I'm going to turn it back over to Susan to go through a little bit more of the specifics on the devices themselves and the application.
So the application of the device of the sensor, of course, we're going to wash our hands and we're going to put gloves on. Determine the location that the device is going to be placed. We need to always rotate sites. Okay. And a lot of there's some great videos on each website, like whether it's the Libre or the Dexcom or the Medtronic of how to apply the sensor. But we always clean the area with alcohol and allow it to air dry. Some of them tell you to clean it with soap and water and then to apply the alcohol. So because of the time frame, I feel like that it's worn, they want to make sure that the skin is very clean. Position the applicator and choose the site. As I said, rotate your sites. A lot of these devices indicate that it should be in the upper arm, but not in an area where it's going to be easily touched or bumped or pressed on, even as the user sleeps, because that can give some false information or some not having information at all. So with the next slide, it kind of shows these devices that you're going to use. The Dexcom 6 and the Dexcom 7, G7, and the Libre style. It's a round device, as you can see on the screen, and it looks very user friendly. All that you have to do is screw off the cap. And some of the devices, you're going to have to take a picture with the smartphone. Okay. to scan the code on the new sensor so that it connects, it reads with that sensor. And then once you remove the cap, you're going to take the larger portion and you're going to press it against the skin of the site where you're going to place it. And it's just a press in and press out. And some of them have a button on the side that actually makes that happen. The Dexcom 7 does have that. And then it leaves the sensor in the skin with the adhesive border around the sensor. And some of them, most of them, have a cover dressing so that we can make sure that it stays in place. And one question that came to my mind about this sensor whenever I was preparing for this presentation was, can it get wet? And people can shower with it, they can swim with it, they can exercise with it. It just can't, the recommendation is for it not to be immersed more than 30 minutes at a given time. So you want to always make sure that this goes into fatty tissue. And the recommendation is basically the back of the arm. Some of the devices, the model says you can place in the abdomen. So it's going to depend on the make and the model of the devices. There's some great videos out there on these sites that I would recommend if you have a resident move in with a Dexcom G7, that you look at that video. They're very short, but very to the point and give great information. So the frequency depends on what the practitioner orders. You can, with these real-time monitors and devices, you can send it to your family member, you can send it to a friend, you can send it to your practitioner. Okay, it's wirelessly driven and it can be sent out to the practitioner. The frequency of checks of self-monitoring should also be determined by the practitioner. And the facility, we got to keep up with these monitors. If they are someone that does not use the smartphone for the app, we're going to have to keep up with the monitors, whether that goes in the cart, whether that stays in the resident's room. Of those scan types, how are we going to keep up with the monitor to be able to read the sensor?
All right, so we're going to transition now over to just some hypoglycemic management goals for our patients. And this is just kind of a printout of some of the data that you can see from the continuous glucose monitor device. The management goals, the diabetic management goals, they are set by the provider and the patient. We have here like a goal set for A1C therapy of less than 8. I know through school and whatever many of us learn, less than 7 is the range that we're looking for. But often in the elderly, like we're servicing typically in long-term care, those 65 and older, a goal of 8 or less is acceptable for an A1C. And we're going to set a goal for the time and range. Again, these goals are set by the practitioner along with the patient. And these goals are not input into the reader itself. I do want to point out one piece of information that the reader will give you, and it's called the glucose management indicator. You can kind of see that under the glucose metrics in the middle on the right, and you can see that it says 7.5%. So this glucose management indicator, that's an estimation of an A1C level based on the readings from the CGM. And they may not be as quite as accurate as a lab draw for an A1C, but it's a pretty decent estimate from what they found. So a question is like, can they enter their goals into the CGM device to try to target that? No, the goals are typically not entered into the device itself. The goals of the A1C and the time and range, like I mentioned, that's set between a discussion with the medical provider and the patient. You'll just base that on the patient's history, what they're agreeable to, what kind of diet and exercise they're agreeable to. And we want to set goals that are achievable for them. CGMs automatically monitor blood glucose levels and they display them. They often have features like trend arrows and alerts. Users may be able to set the target ranges and customize those kind of settings for alerts, but the primary function of the reader is to display the data collected by the sensor and to take this data to the medical provider and use it, like I said, to assess the progress toward the set goals. I'm trying to work between two computers here. And okay. Um, Hypoglycemia and long-term care. So why are older adults at risk of hypoglycemia? There are a slew of reasons this could be, but what we see a lot is variable food intake. Sometimes they feel like eating, sometimes they don't. They could be sick and not want to eat more. Cognitive impairment, major one. Polypharmacy, we all know that exists. And in the elderly, you really start to see decreased renal function. Insulins can be a more frequent cause of hypoglycemia than just our oral therapy. So, some common insulin regimens that we are all used to seeing are basal insulin, basal bolus regimens, and premixed insulin. So, just kind of a brief overview and refresher of the insulin regimens. The basal insulin, that's a long acting insulin regimen that we give once or twice a day. It gives a small but a consistent stream of insulin, and this helps to process the sugar in your bloodstream when you are not eating. Typically, for these, we see the long acting insulins used. So that would be kind of like your Lantus, your Basaglar, Levmir, and Triceba. Basal bolus therapies, that is a basal insulin used along with a bolus insulin. So in diabetic, that's a diabetic management approach that uses the combination again of the long acting insulin to maintain kind of a consistent background insulin levels and short acting insulin to cover carbohydrate intake at mealtime and correct blood sugars. This approach aims to mimic the natural release of insulin from the pancreas. We already covered the basal insulin examples, but the bolus examples that we would use kind of at the mealtime therapies would be rapid acting, and that would be VSAP, Humalog, Novolog, and Apidra. The short acting insulins that we see are Humulin R and Novolin. We don't see premixed insulins quite as frequently, but that's another regimen that we see. And this is just a combination of short and intermittent insulin into a single formulation. And this is just to simplify the insulin administration. This regimen is also typically administered twice daily, and that's offering both basal and prandial mealtime insulin coverage. Those that we see are regular insulin and NPH, like a 70-30 or a 50-50. Pre-mixed insulin, insulin Lispro with insulin protamine, that comes in a 75-25 mix or 50-50. And the insulin aspartate mixed with the protamine. We see 70-30 and 50-50 on that. And I'm going to send it back to Susan now.
So one of the main goals with the CGM is to prevent hypoglycemia events. So we need to be able to identify the symptoms. And I have a great tool that I give my facilities that has these little figures on there, and it shows these symptoms, signs and symptoms of hypoglycemia. You know, hypoglycemia comes on typically very abruptly. So hopefully this will prevent that with the CGMs. But shakiness, sweatiness, dizziness, some of them can become very combative. They can even become unresponsive. So we teach that any blood sugar less than 70 is considered hypoglycemia. And that's kind of the standard of practice from everything that I've read out there. So what I find in my facilities oftentimes, maybe skilled nurses know exactly what to do, but a lot of times the med techs or the folks taking care of assisted living, they don't know what to do for a hypoglycemic effect. So we need to make sure that we have available for them some type of the rule of 15 to consume 15 grams of a rapid acting carb. such as a juice, a soda, some glucose tablets. I've even seen things like honey. So something that they can take easily, not like giving them a Snicker bar and say, hey, can you chew this up? Because they're already not feeling well as a rule when they have a hypoglycemic event. So, and then you have the non-conscious resident who they're not able to swallow. They're not alert enough to follow these simple commands. And in a lot of our states, we don't have the medications like glucagon to be allowed to be injected. And I know our state in South Carolina, they cannot do any type of injection such as this. I know there's an intranasal glucagon, and if we can get that approved again through insurance. So we need to make sure we have some protocols because I don't see those oftentimes in assisted living. They may have to call the MD if they have a blood sugar greater than 300. Sometimes I don't even see that of how we manage hyperglycemia as well. So we need protocols in our facilities. I feel like in most of our skilled facilities, we do have this, and we have nurses who know how to manage that. But oftentimes in assisted living, we don't. So I always teach if they are able to drink, give them juice. Give them the most simple, rapid thing because a liquid medication, I mean, a liquid 15 grams of carbs is going to work quicker than something that they have to chew. Okay. So we just need to make sure. And then we teach them to follow up 15 minutes later with that finger stick. So hopefully our CGM, one thing with the CGM is it does provide continuous real-time glucose data, allowing for proactive treatment so that we can hopefully catch a hypoglycemic effect before it happens. Hypoglycemia makes the resident feel really bad. Once we get the blood sugar up, just because we have the blood sugar up to 120 doesn't mean that they automatically feel a lot better. So that lags sometimes. But the continuous data from the CGM helps in early detection. So hopefully we can prevent these hypoglycemic events. Um, Also, the pros of it is it reduces the need for finger stick testing. I was just, and I teach this in my classes, that if a resident receives an order for 4 times a day finger stick blood sugars, that is 1,460 blood sugars annually, not not including any of the PRN or the follow-up blood sugars that we do in 15 minutes after a hypoglycemic event. So it saves nursing time as well. But all the guidelines tell us that if the CGM is not reading correctly, it doesn't pair up with the symptoms, that then we have to go back to the finger stick blood sugar. Okay. It improves the quality of life for the residents so they can constantly know what their blood sugar is, whether they're scanning or whether they're just looking at their smartphone or their device for this readings. So it really does benefit them. And then of course the cons. The cons is the measurement lag time. Okay. We said earlier because we're checking interstitial fluid, it lags by 5 to 15 minutes. Is it always accurate? Do the symptoms and the readings pair up together? In that event, you need to do a finger stick blood sugar. And then the technology and the training of the staff and the families and residents. Okay, maybe they're taking them out for a day and they get this beeping alarm and they don't know what's going on. So we got to make sure we're taking into consideration that they will have some outings, and we need to train the staff and the families and the residents. And then the expense. Of course, the CGM is more expensive. Um, Maybe that will change eventually. I used to never see folks on that are type 2 diabetics ever be on insulin, but we do see that now more and more That is kind of a standard of practice that
Mhm.
we do a great job, I feel like, managing blood sugars better than we ever have. So those are our disadvantages, but I feel like the advantages of this outweigh if we can get the insurance to cover it for that resident. And then, of course, a loss or misplaced reader. We have to have somewhere that we know in our facility where we're going to store it. Okay. And then the device malfunctions. You cannot reuse a sensor. I had somebody say, well, if one comes out, can we just put it back in? You cannot do that. Okay. You cannot put that sensor. It's going to require a new one. So that could be some additional cost. Of course, if insurance only allows a certain amount of sensors per month per period of time. So those are some disadvantages, but I feel like the advantages outweigh that.
All right, and we'll wrap it up here real quick. We've got Brandy back on, so we've got a few minutes before we can take some questions. But anytime you do a CE, you've got to mention some case studies and clinical evidence. So one of the bigger studies that stood out over time was the Diamond study, and that took place between 2014 and 2017. And that was just the outcome of that was that it did show CGM use did improve um, the reduction in A1C versus just usual finger sticks. This was done in type 1 diabetics. Like we've mentioned, we see less of that in long-term care than we see of type 2. But if you want to know further about that study, I would go read back into the Diamond study. There are studies out there that have shown CGM in hospital settings definitely improves glucose control. And there are plenty of patient success stories out there with CGM adoption and how they have become more adherent to their regimens and manage their hypo and hyperglycemia better and made adjustments to their daily lives. There are several real world application studies out there, and one to note was there was a study of 250 patients using the CGM for 6 months, and they saw a 1.2% average reduction in A1C and a 65% fewer hypoglycemic events and 80% improved medication adherence. From the Diamond study, I will go back for a second and just tell you that it was a randomized trial. It was across 24 endocrinology practices in the US, and there were 105 people out of the 158 that were in the CGM participants and 53 in the other, in the traditional. The results that were seen were the CGM group, 93% of the participants that use the CGM, they use it 6 days or more a week over a 6 month period. And the mean A1C reduction in this was compared to baseline, and their baseline A1C in the study was between 7.5 and 9.5%. But the A1C reduction in the CGM group showed between 1.1 and 1.2% over the 24-week period. And those in the traditional finger stick category over the 24 weeks, they saw a 0% to 0.4% reduction in A1C. So I do think that's quite significant. The future of CGMs, as always, we're looking for improved accuracy and convenience. They are looking at more integration with insulin pumps and longer lasting non invasive sensors. What's next? Some artificial pancreas systems that are trying to be developed. Back to the needle free CGM that Susan mentioned, where it talked about optical and sweat use. So that is kind of interesting. And like she said, the question would be, how can you produce tears or sweat on demand? That's not exactly what they're looking for when I kind of read further into it. For the optical continuous glucose monitoring, that's going to work by using a light somehow to measure the glucose levels in interstitial fluid. And for the sweat's directed to a tiny microfluidic channel in a collection chamber. The glucose levels are collected from the sweat and measured before it flows back out. In these devices, they're also looking to monitor heart rate variability and body temperature along with that to identify signs and symptoms for early hypoglycemia events. The Freestyle Libre 3, which she mentioned, that is already available. And the good thing with that is that it has gone from use in 4-year-olds before for most of the technology to now that can be used in 2-year-olds. So in your type 1 diabetics, that's going to be much more useful, especially in kids. They don't want fingers stuck all the time. So kind of in conclusion, CGM enhances diabetic management. Of course, we've got to get buy-in from the staff and the residents on the use of the CGMs if they don't already move in using them. It does help prevent complications and gives real-time insights. Hopefully, it will encourage patient engagement and adherence to their own healthcare goals. And our nurses are going to have to play a key role in that. So, what can we do as healthcare professionals? We can advocate for CGM accessibility, encourage patients to use it for proactive diabetes care, and just stay updated. As we said, more people may start moving in and already be using the CGM technology. And we want to be able to continue to help them, show them more support, let them know they're knowledgeable. That will make them feel more comfortable with their move ins and transition to care, where most people want to stay in their home as long as they can. And the adjustment periods may be easier. We want to make them feel comfortable. We know, we understand them, and we are here to support. So, with that, thank you for your time and attention, and hopefully you found this useful.